One of the things that we saw was a very rapid pain relief. If you compare it to other ablative therapies, sometimes we expect pain to increase before it decreases.
What we found that's really important with respect to the OPuS One study at 3 months, which is what your question was, is that pain relief is not only early on, but it's durable at 3 months. And that's valuable because at 3 months in these patients who may have a shorter life expectancy, their quality of life really needs to be impacted because they want to get back to their normal therapies, they want to get back to their usual routine. And what we found is they get that early results and it's durable at 3 months.
So I think that the road is wide open for this therapy, okay? When you compare this therapy to something like external beam radiation or specifically SBRT, those are destabilizing events to the skeleton. So when you're talking about the axial skeleton, you have axial loading of weight. And if you do something that's destabilizing, there is a high risk of delayed skeletal events such as fractures. So if you look at all of the studies that are out there regarding SBRT, the fracture rate in lytic lesions is extremely high. So I see this therapy being adopted much earlier in the course and certainly can be combined with radiation, but before radiation with lytic lesions specifically.
So RFA offers a really unique opportunity. The energy from RFA is not too strong or too weak, and it provides a safe, if you will, middle ground, especially in the spinal cord or in bone, to avoid maybe injuring the nearby tissues. So unlike other technologies which may be too powerful or weaker technologies that may not allow good treatment of, say, lytic metastases in the bone, RFA is a good middle player. But it is excellent at providing relatively immediate relief. And so by that, just as Dr. Levy mentioned earlier, allowing it to sort of fit within the continuum of care of the cancer patient, you can now provide it early on and then get that immediate pain relief and then get patients back and moving again.
I'd like to add to that actually.
Yeah.
In addition, the heat-based therapy is definitely preferential when you're thinking about mechanical stabilization.
I think the biggest value that OPuS One brings is the size of the population we're examining. Much of the interventional literature lags behind compared to other subspecialties in terms of the size of clinical studies. And the existing literature that's to date, whether it's in radiation oncology or medical oncology, with respect to bone metastases, is somewhere in the neighborhood of, say, 100 to 300 patients. And what's nice about this study, where we're combining 15 centers around the globe, aiming to get 250 patients into this clinical study, we're going to be on the same level of clinical data collection that the other modalities are being tested against.
Yeah, I agree. I think it actually is going to add more, not just to the interventional radiology community, but to the patients. And the bottom line is we're seeing pain relief so fast here that, like Dr. Bagla already mentioned, you're able to keep them on protocol, which is huge to these patients. The oncologists need to keep these patients on protocol. The patients need rapid pain relief, especially when they're at the end of their life, right? Someone's going to live 6 months, waiting 4 weeks for pain relief is a big deal.